talk about the autonomic nervous system again. This will be video 3, and I'm going to talk more about the neurotransmitters, drugs, and receptors, and then tie that into the functional significance of parts of the autonomic nervous system. So you can see this again. I did show this in the first video, and I talked a little bit about the preganglionic and postganglionic neurons. You can review that if you'd like. So let's just get started here. So drugs that block your nicotininergic receptors, if they affect your autonomic nervous system, are going to block this area here. Now, you have quite a diversity, though, of nicotininergic receptors. You actually have, there's 5 subunits of nicotininergic receptors, right? And so in your muscles, like your skeletal muscles, like your somatic nervous system, those contain alpha, beta, gamma, delta, and epsilon subunits, and there's probably multiple ones of each one of those. There's multiple alpha and beta subunits, but only, I think, alpha 1 and beta 1 are used in those skeletal muscle nicotininergic receptors. If you block those nicotininergic receptors with certain drugs that are non-depolarizing drugs, you can cause paralysis. There are other drugs that bind more specifically to the nicotininergic receptors found in the autonomic nervous system, and those include trimethophan, methylamine, and hexamethonium. These receptors are alpha and beta receptors. The nicotininergic receptors are alpha and beta subunits. I'm not talking about the adrenergic alpha and beta receptors. I'm talking about something different. I'm just talking about how they classified receptor subunits for just the nicotininergic receptor. So these have alpha and beta. I think there's like 9 alpha and like 3 beta subunits. If you go ahead and do the math, take some number, choose some number, and you can figure out how many possibilities there are, how many permutations there are for the alpha and beta receptors. But there are a lot, even, just for those. And that's aside from your inner muscles, okay? So, when you block the autonomic ganglia, you have different effects. It has different effects in your body. Generally, though, the general rule is that your parasympathetic nervous system rules, and that's because at basal levels, your parasympathetic nervous system is mostly operating, and in your fight-flight, though, then your sympathetic nervous system kicks in. So if you think about it that way, any organ that is just innervated by your sympathetic nervous system, then when you use these ganglionic blockers that I just mentioned here, those are going to be inhibiting just the sympathetic aspect of what's happening. So in, say, your blood vessels, for example, those are only, unless it's in your cavernosum, which causes erection. Everywhere else, you're pretty much stopping the sympathetic nervous system. So in your veins, if you use these ganglionic blockers, you're blocking the constriction. So you're causing venodilation in your arterioles, like in the distal parts of your body or near your skin. You're causing vasoconstriction. You're constricting your arterioles. Okay? So that's what happens when you block. But the opposite of that happens. So you cause arterial dilation and you cause vasodilation, which decreases blood pressure. If you have too much of that, it's probably going to kill you. So yeah. So you probably have to care about how much somebody has of that. So there are also drugs that prevent the release of acetylcholine. Drugs like Botox is the short for it. I think it's like botulinum toxin or something. Botox. It blocks the actual release from the vesicle of the acetylcholine onto the membrane to fuse with it and release the acetylcholine. That doesn't happen very well when you take Botox. Now, if you think about this, like if you were just to take a bunch of Botox, or enough of it for your whole body, it would prevent your whole autonomic nervous system from functioning, because you wouldn't be able to get the postganglionic neuron to be stimulated, right? And also, because it's the acetylcholine we're talking about, the acetylcholine. We're not talking about the receptors. We're talking about the acetylcholine, which is a common activator of all the nicotininergic receptors in your body. Guess what happens in all the muscarinic receptors we're talking about? Guess what? You can't stimulate any of them because it doesn't get secreted. So you can't move, and none of your autonomic nervous system works. So that means your heart, I think, beats at like 50 beats per minute. It doesn't do anything if you don't get any stimulation from either one. Which that's if you completely shut down the nervous system. I might be wrong about the number, but I thought it was 50. But then again, I guess the parasympathetic nervous system wins somehow from what I read. Anyway, so going back, basically you might as well just cut your head off, because everywhere your brain tries to interact with your body, it's going to use cholinergic signaling. So that whether it's your skeletal muscles or your autonomic nervous system, it's like cutting your head off. So actually, Botox, there's like A through H. Like there's like, what is that, like 8 versions of the Botox, basically, that are produced from the bacteria. Like it causes food poisoning. Yeah, it's pretty freaking serious. So if you eat these bacteria or in the toxins that they've produced, it's not a good thing. It's the most toxic toxin in the world, actually. I can't remember if it's A or H that's the most toxic. But for how many nanograms you have to kill you, it's pretty low. You don't have to have that much of it. So, and the reason is it blocks the acetylcholine signal. Let's see. There's also other drugs like I think Vesimicol that blocks this too. That prevents the release, or I think actually the pumping in of acetylcholine into the actual vesicles, if I remember right, or at least the release of them, something like that. For the target organ, there are drugs that prevent norepinephrine from being released, or dopamine. See, the actual sympathetic nervous system, it actually includes dopaminergic signaling as well, in your body even, but it's mostly epinephrine and norepinephrine. But there are drugs like alpha-methyltyrosine that block the production of dopamine, norepinephrine, and epinephrine. And it does that by blocking the step between tyrosine, I think dihydroxyphenylalanine, beta-tyrosine hydroxylase. It blocks that step, so you don't go any further beyond tyrosine. You don't make the dopamine, you don't make the norepinephrine, and you don't make the epinephrine. That one is pretty serious. It would affect your whole body and your sympathetic nervous system. I think across the blood-brain barrier would affect your brain as well. Pretty much do the opposite of what Strattera is supposed to do. So if you have, say you have a tumor here above your kidney in your adrenal medulla, that's called a pheochromocytoma. And if that happens, sometimes alpha-methyltyrosine helps with that because it blocks the production of epinephrine. Because under this disease state, you're producing too much epinephrine and norepinephrine. It's going through your body. It's causing vasoconstriction and all kinds of problems when there's too much of it, right? It's like you're in the fight or flight situation all the time. That's not a good thing, okay? There are other drugs that prevent the release of, or prevent the pumping in of norepinephrine into the vesicles so that your sympathetic nervous system can't really release norepinephrine eventually. Initially, there's actually a bunch of norepinephrine comes across because it can't go into the vesicle, and it overloads the norepinephrine transporter, which is what cocaine blocks. So it causes like this real high at first, but then all of a sudden you don't get any norepinephrine in. You have hypotension, you're depressed, and stuff like that. If you take Reserpine, this was prescribed to psychotic patients before. It lowers blood pressure. It does some good things, right? So that blocks VMAT, which is the vesicular monoamine transporter. So that's what Reserpine does. There's other ones like guanethidine, and I want to say guanidrol, maybe, I might have got that wrong, that block, they either displace the norepinephrine in the vesicle so that not as much comes in, because you got to figure with these vesicles in your terminal bulb here, it's pumping protons to create a gradient of protons first. Then that gradient of protons, that actual energy that's caused by just having a bunch of protons in one place that want to come out, each time it comes out, it doesn't just go in or come out randomly, it comes out usually. And if you can cause that positive charged molecule binding to create a change in the structure of some protein, you can keep causing some process to happen. Well, this results in ATPase. This results in pumping of the neurotransmitter into those vesicles. So drugs that displace norepinephrine, though, it's using that energy just to put some other molecule in there instead of norepinephrine, which decreases norepinephrine signaling and also causes hypotension and probably depression. So yeah, that's I just basically wrapped up the actual general structure, drugs that just generally affect your autonomic nervous system. When you think about it, when you affect cholinergic signaling, you're affecting a lot of things in your body just because this is your presynaptic neuron. And so the more that people find drugs that can affect either like the muscarinic receptors specifically or specific nicotininergic receptors, the more people are able scientists are able to figure out how to target specific ones. They might actually be able to target at least some specific autonomic ganglia versus others. But who knows, maybe that's even genetically determined. So it's kind of an interesting thought. So moving on, now I'm going to look more at the rest of the body here. So we'll start. I did want to just mention one thing I didn't mention in a previous video. I didn't talk much about the sensory pathways for the autonomic nervous system, which I was really interested in. I read a little bit about. So at certain organs, like ones that sense how high your blood pressure is, the baroreceptors, which are, I think, located in the carotid artery, and then also located in your aorta, or say your chemoreceptors that sense the amount of carbon dioxide in your blood, like the acidity or how much carbonic acid there is, for example. Those receptors, those signal other neurons that go back, that are afferent neurons that follow the same pathway back, either like through the splanchnic nerves or through nerves that go back to your sympathetic chain ganglia. The end result, in the case of the splanchnic nerve at least, is it goes back to your intermediolateral cell column, cell body. No, I'm sorry, I have that wrong. Sorry, before it reaches the intermediolateral cell column, it actually branches off and it goes to your dorsal horn, gray matter in your spine, and then there it synapses, and then it goes up through the spinal thalamic pathway, which is the same pathway involved in pain. It goes through that pathway, goes up to your the solitary tract, the nucleus of the solitary tract, and then from there, some of that information goes directly up to the thalamus. I think the ventral part of your thalamus. The other parts go up to your parabrachial nucleus, which is around your superior cerebellar peduncle, from what I read in a textbook. In fact, that textbook is called Neuroscience. In fact, and I want to actually also mention this real quick, a lot of the drugs, the information that I've learned about the drugs, I've read in a book called Principles of Pharmacology. So just look that up and find the newest version of that. It's a good book for learning what drugs do and learning the physiology and how the drugs change pathophysiology, and learning pathophysiology. But anyway, so this afferent information goes to the nucleus of the solitary tract, particularly the caudal part. The rostral part, which would be more superior, is more involved in taste, perception, but the caudal part receives your autonomic afferent information Some of that sends reflexes back and changes things if it receives something. Particularly in your digestive tract, this is probably directly relevant. I'm thinking because when you start eating food, your body senses it. It sends information up there and sends information back, tells it to maybe release gastrin, to relax, so that food can come in, does a bunch of stuff, right? A lot of that can even happen near your nucleus of the solitary tract. Then there's the parabrachial nucleus that I was just talking about, that is by your superior cerebellar peduncles. There, that sends information up to your hypothalamus. Some of them may go directly from the nucleus of the solitary tract up to your hypothalamus up here. And when it does, it can do some math and then figure out what it needs to do. Some of that goes up to your forebrain, up to your medial cortex, like your anterior cingulate cortex, which I talked about in the context of the Stroop effect in a previous video, and also up to your prefrontal cortex and maybe your orbitofrontal cortex. Here, I'll just actually show you real quick. This would be this is the anterior cingulate cortex here. Remember Brodmann's 25 is in here. That affects your mood and hunger and stuff. That's like right in this area. Your hypothalamus would be down. So I can overlay this, I think, as I did in the previous video. Your hypothalamus is somewhere in here, in this region here, in the brown area. And this is the forebrain here. Some of that information goes here. Some of it goes to your insula and your gustatory complex in your brain, which would be buried. See, this is the sylvian fissure here. This is your temporal lobe, and then this other part is your parietal lobe and your frontal lobe. If you go into this part, you're going in closer to the insular cortex, which is a little bit of cross-sectional area of that, where you actually perceive and you can actually feel like things that are happening in your organs if you're deprived sensorily. That your insular cortex is in this region here in your brain, if we're looking at it on a coronal plane, okay? So moving on to the rest of the body. Didn't really talk much about that. So starting with the eye here, drugs that cause constriction of your iris, that cause pupil constriction, would be procholinergic drugs. So I'll draw that as green, and I'll say P for parasympathetic. So P. That results in pupil constriction. And there's a lot of drugs. There's neostigmine, ambinonium, edrophonium, physostigmine, pyridostigmine, all those drugs, I would guess, even galantamine and rivastigmine and some of the, and donepezil, those actually affect Alzheimer's disease, the latter three, because they cross the blood-brain barrier. But those drugs are more likely to cause vasoconstriction because they inhibit your acetylcholinesterase. And I didn't talk much about it, but back in that other sheet where I showed the presynaptic and the postsynaptic neuron for your autonomic nervous system. In between the two, when acetylcholine is released, if you're blocking acetylcholinesterase, which breaks down acetylcholine temporarily, if you're blocking that, then you're allowing acetylcholine to linger in the synapse longer. So whenever you have a reduction in the amount of cholinergic signaling, like you do in dementia and Alzheimer's disease, it helps to have such drugs. Well, if you directly apply those to the eye, you cause ocular constriction. You cause constriction of your iris. So, also, drugs like pilocarpine, cevilamine, and other procholinergic drugs. I can't think of any other ones right now. If you apply those to the eye, those are going to cause pupil constriction. Okay. As far as if you want to use the cholinergic pathway, if you want to inhibit the cholinergic pathway, and you want to cause dilation of the pupil, you can also inhibit the parasympathetic nervous system. And when you do that, that's going to cause what's called mydriasis, or pupillar dilation. That's right. Mydriasis. If I spelled it right. Drugs like that could include atropine. Atropine blocks your muscarinic receptors. Particularly in this situation, probably the muscarinic 3 receptor. I don't know if glycopyrrolate blocks it. I'm trying to think if there's any other ones. I can't really think of any other ones that block your muscarinic receptors in your eyes, but maybe any of the other anti-muscarinic receptors would at least have some effect. But atropine is usually, I think, used to block your cholinergic signaling and cause dilation of your eyes. In the case of your adrenergic nervous system, there are some drugs that block adrenergic signaling, and in doing that, you would be causing pupillar constriction again, what's called meiosis. So those drugs are causing pupil constriction. Drugs like that would include, I think, timolol, levobunolol, and cardiolol. Drugs like that, which are also beta blockers that are specific. I think they're specific. They might know, maybe they're not specific, because they also, I think, might hit alpha receptors. I'm not sure about that. But those drugs that I read about in a textbook, Principles of Pharmacology, those can block the adrenergic nervous system in the eye and cause constriction. Let's see, what else? If you help the adrenergic nervous system, drugs that it talks about, at least in that book, relate to ophthalmic hyperemia. So if you have ones that promote, actually, I'm sorry, I meant, let's do S. Oops. Because this is parasympathetic, we're going to go with sympathetic. And then if we promote the sympathetic nervous system, we're using drugs that agonize, like your alpha-1 receptors, for example, which, actually, I should say, the ones that cause pupillar constriction, those drugs are pretty good for when you have glaucoma in your eyes, and that's because it changes where your iris is and how much pressure is on your iris, and it actually can cause a relief in pressure in your eye for some reason, and that's good for, it also might help some of the fluid flow out of your eyes. There's less ocular pressure. But in the case of the sympathetic drugs that help it, those drugs like Visine is the brand name, I think it's called tolazamide, that agonizes your alpha-1 receptors. That causes constriction of your arterioles that are in your eyes. So if you have red eyes, it causes the red eyes to not be as red anymore, because less blood is going into your eye. So we'll just say minus ophthalmic hyperemia. Yeah, good enough. All right, so that's it for the eyes. Let's see, moving on to your lacrimal gland. I don't know actually about drugs for that. for your palatine, your parotid gland, and your submandibular and sublingual glands. Drugs that affect that. If you increase your muscarinic, your acetylcholine, cholinergic, parasympathetic signaling of those, you're increasing the release of saliva in those organs. So, drugs, I don't know that we actually ever try to specifically increase your saliva. But if we did, we might use like carbachol or neostigmine or any of those other drugs. If you could apply those directly to the saliva glands, you might help that. But usually they're trying to stop saliva. Like if you're in surgery and like they don't want you to choke on your saliva or something, they'd be using like atropine or glycopyrrolate, any of the or like say methscopolamine, drugs like that are anti-muscarinic drugs that don't cross the blood-brain barrier and go up to your brain and mess with your brain, that stay in your body. They might use those drugs to keep you from actually hypersalivating and choking while they're doing surgery. So drugs that do that would be anti-parasympathetic drugs, dry mouth. Actually, now that I think about it, there are drugs. There's, let's see here. Salivate, I'll just put salivation. Drugs like cevilamine and pilocarpine are actually pro-muscarinic. They actually agonize muscarinic receptors, and those cause the flow of saliva. So either they bind directly to the muscarinic receptor. I think in both these cases they do actually bind to the muscarinic receptor and agonize it. They're not necessarily the same as acetylcholine, and they do cause salivation. Okay, so moving on, we'll go to the lungs here. Just get rid of this to make space. So for the cholinergic, well, we like the most salutant drug would probably be like epinephrine, right? So I guess we'll start with the sympathetic nervous system. So we'll go S. When you do that, you cause bronchodilation. And that's with drugs like epinephrine, levobuterol, isoproterenol, metoprolol, drugs like, let's see, I want to say albuterol, different drugs like that it just agonize either the beta 2 and just the beta 2 by itself, or the beta 2 and the beta 1 even, which can also affect your heart. But still, if you're agonizing the beta 2 receptor, then you're causing relaxation through the GS pathway, which basically ends up inhibiting smooth muscle contraction. Okay. If you were, I don't know that there's really any drugs that try to inhibit that I can think of right off the top of my head, but also if you have chronic obstructive pulmonary disease,